introduction of me also. So I'm very proud to show that I already worked last century on this e-government thing, which centralized the tax administration system, which became the base for the e-tax system. And then I was chief architect of the National Electronic Health Record project. Then I was also architect in a project where we piloted the X-Road in Finland. We tried in some region of Finland to connect the health records and social records system using like just a test environment to demonstrate that for the Finnish people that if you bring the software over the Finnish Gulf from Estonia to Finland, it still works. So we had to do this pilot project. And then I was architecting a solution for the major private medical lab in Estonia for the direct access laboratory. So patients can order tests directly and get the results back. And also the data goes to the National Electronic Health Records automatically. So even the private healthcare, I'm going to the lab, I'm taking this by some simple test there, like some immunology tests, and then I see the results through this portal, but also my GP or whatever doctor I go, they see the test results through the EHR system. Then there was 5 years ago a big feasibility study about, we call it personal medicine, but I think in other parts of the world it's often called precision medicine, which introduces the genetic component to the healthcare. But also here we analyze these different opportunities of creating more value out of the integrated health record system. So how to really now introduce the decision support to the physicians and to the patients. So we traveled around the world and searched for some ideas. Then I worked also with some international consultants to develop something for the ITU and WHO, this kit for digitalization of a country. Now I'm working here in Mongolia already 3 years, and then also I've done some other projects in some other countries regarding this how to make sense of this experience in some other conditions. So let's look at this Estonian health information exchange platform a little bit more closer. So we have decided to cover in one registry of data the whole person's life events from birth to death. I integrate all healthcare organizations of the country. It's a policy, it's mandatory for all healthcare providers to share the data. And we also allow access to the patients. So these are like the main things of concepts. So we have tried to interpret what it means patient-centric or person-centric healthcare, and this is what it comes to the information sharing. So we have from life to birth to death everything. We have all healthcare, and also patient can access. So this is like the driving concept. And this analysts I mentioned also in the first presentation, who considered us still like the top digital health, they have analyzed many different countries, like the well-known digital health countries, Canada and Denmark and Sweden and UK and Australia, and we still have a little bit to provide. So there is something still interesting for analysts also. And for example, not Germany is not maybe the best example of this digital health societies anyway, but what they have analyzed there was the policy activity. So if there is strong policy of digital health in the country, is the country ready to exchange information? Do you have internet and do you have everything in place this to work? What is the actual use? So you may have theoretically all policies and equipment and everything, but do you really use? Do doctors use the data? And here we got these scores which are combined into this overall index. And I can just show you. So if I'm opening the patient portal, then I can use my ID card here, because virtually all computers that you buy in Estonia have the card readers. But when you apply for the e-residency, you get this thing, and also you get the small reader, so you can just plug it into the USB port. So this is the physical thing that you get. And then if we just go to this internet site here, then I can just log in with the ID card. And then it asks my PIN code. And this is my health. So here what I can see my, let me make it even bigger here. So what I see here is this is just quick update of my data. I have valid insurance. My family doctor is Svea Rosenthal. My ID. I can go here and just see update my patient record here, my wife, contact person, my address, and then there is information that is taken from the population registry. So my parents here and my children here, and this comes automatically from the population registry. But I can adjust it in the EHR a little bit, add my contact numbers and stuff. And then insurance, family doctor, I can add new people who can have access to my data. So I can just put here some first name, last name, and personal identifier, and then choose which level of access I give to this person to my health information. So maybe the one is that the lowest level is that I can only allow to go to pharmacy behalf of me. Okay. And then there are higher levels, view data and full rights, and then combined pharmacy and full rights. So I can give access to my trustee, somebody I trust, or some not licensed physician, like some traditional medicine provider, somebody. I can just give access to view my data and then get second opinion on this. Then here is, I have just one child here left because the rest are already over 19 years old. But basically I can switch here the roles. I can be myself, and I can see the records of my underage children. Okay, and then there is this quick access to different dimensions of the documents. In general, I can just start from the top and see what I can find here about me. I can see some case summaries and examination results, and this is now we are entering the field of usability. So how to really give this access for the patient so that they understand what they see here. So I think this is already a little bit over my head. I'm educated. I have been trained 10 years that understanding these words. But if you are just the first time encountering this thing, you need some guidance probably. Where is my lab result? Where is my prescription? Where is my occupational health consultancy document? So I can try to see like my health declarations here. And okay, I don't see anyone. Okay, there is a button, invalid and cancelled. Okay, let's see, maybe here. Okay, there is one expired health declaration that I made because I had to renew my driver license. I did this, so I can see my health declaration here. Some is in English, but the rest I need to just translate here. And then you can see like lifestyle, do you drink alcohol, how many units, do you smoke, do you use some other substances, working environment, allergies, some nervous system complaints, eye and vision, like this kind of declaration. This was in this animation movies. That this I have to fill in order to really get my GP to provide me this certificate. Okay, and then also any document in this system has this access control buttons. So I can say that I want to lock this for doctors. I don't want any doctor to see this record. And I can lock it to my trustees. So I have maybe introduced some friend or a parent or child that takes care of my things here, but I can then close. And then if I try to close it for the physicians, then I get this that okay, you can do it, but you have to understand that after that your healthcare service may be not that good quality anymore, because you have hidden some information about you. Okay, and then if we look at here like some case summaries, so I have been to I'm typical Estonian male. Going to doctor is so how to say it's so important event that I'm always going to the doctor with flashing lights. And okay, here is some occupational health because I wanted to have the life insurance from the bank. Then bank required me to go to this checkup. So the physician made this checkup, so I can see that there is a date of visit, what type of visit it was, times. It's insurance review, the ICD code. And then there is some text that the physician wrote. I think that Google Translate, you have to be very careful with Google Translate here. But basically there are some findings that they collected, like about blood pressure and some other, they measured this lungs, some respiratory stuff, then like this kind of simple things, studies, electrocardiographic load test, Then lab result. I can get some more data about it was done in this private lab actually, but this not GP but this occupational health physician took my blood test and sent it to this private lab. And then there is some summary and then basically the signature information. So this is how these documents.
Do you get any billing information on there?
Sorry?
Do you see any billing information on there?
Billing information goes to other place here. Good question. If we go back to the home page, then this is like the health records, okay? Examinations, certificates, vaccinations, whatever you may find here. Then there are my statement of intention where I can give a consent that I don't want my body to be used for research after my death and this kind of how they call it, these future-looking decisions. Then here I can access, I can totally close the records. I don't want anyone to mess with my stuff, so I can just close it. It's and it was not really easy to foresee what the people will do, and basically this feature has been used, but mostly by people like me who are presenting to the how it works. So most of the people never come here and press this button. Okay, then there are invoices submitted to the insurance for my services that I get. So here I can choose some longer period. Search. Nothing. I'm very cheap, you see. No, yeah. Let me try my son. Just. Yeah, there is some. So here you can see the insurance claims submitted. This is in addition to the capitation fee. Capitation fee is not here. Capitation fee, you are anyway insured and you have GP and GP gets capitation. But this is really like unique claims submitted by this hospital, by this doctor. This is a dentist, and this was amount. And this is again dentist. This is a family healthcare center, the same center but different physician now. And these are the amounts that they have submitted the claims. And then there is this logbook. So you can see you can be your own health records security auditor. So you can check that the use of these records has been lawful. And this, you can see different, there are some filters here, but basically if I'm just searching now, then I can see that I have done some queries myself. And probably this is mostly here, because this is every click I make, like a couple of days ago also, I tested something, was done by me. So nobody has paid any interest to my, so let's switch off my should have been there should be a possibility to switch off my own inquiries. No. Search. Yeah. So here I can see that there is a dental report. I went to dentists on the 31 of May. Yeah, again dental records. So this is all dentist. This is the occupation help. Like I just showed this cardiology specialist, family medicine. So I can see, and this is occupational health. So this is the access that has been recorded here to my records. I can see who has accessed it.
Long numbers. Is it identified for that specific document?
Yes. Yeah. Let's. That's also good to know, of course. This is. Yes. This should be the document ID, I guess. Yeah. This is a physician registration ID, and these are the event type. So here is just document registration. There is they have also made a query, and they have searched my health certificate or this certificate, and this is a query. My family doctor has made a query under. And then this is just adding documents. So this is basically also one thing to consider here. So we are designing these FHIR profiles, but what are actually the events that happen between systems? And here, this is the list of events from the business viewpoint. So somebody has submitted a document, somebody has made a query, somebody has fetched the document. So these are the events that actually happen. And then you allocate these different profiles to this event. So what kind of data is transported during this event? Okay. So if any questions later, then I'm happy to come back here.
So when you decided this front-end interface, who decided this?
This is public service, so it's based on public tender, and then there has been some kind of development process and some agreement process behind it. When we first designed it, 2007 something, then it was not that nice. It was much more complex, and so they have invested into simplifying and making it easier to use.
Wouldn't it be more interesting for the patients having actually information that's more important, kind of really being seen it in a informative way instead of just it's
documents? Yeah. Be my guests. And also, you didn't click on this. The thing how to attract actually patients to this kind of system is to really provide valuable services, and we have seen the spikes in the usage, that when you add new services, and not in this system you can't see the images, but my colleagues have implemented also patient portals for the hospitals, and then they have analyzed what is the interesting things what patients actually do in these portals. And one of the top features was ultrasound images of babies, of course. That was like the top that everybody just checked there. And here now, of course, we have this booking system. This is interactive, really. You can book time for the service.
As a doctor, I would have thought that it would be, let's say, obviously you are very healthy, you don't really need a lot of things, but if, let's say, I was a patient who has cardiovascular disease or all this kind of different risk factors, I don't know, someone who smokes, and then health sector would like to give us a message of please don't smoke, and then you have this and this services you can get, and not to help, etc. So if you have like a bit patient-friendly, that was also something I thought, like when you guys were defining patient-centered, it was more about just giving access to the file, but patient-friendly is also being, because the patients are not really, if you have all these tests, etc., all these results, if it's not made it simpler for you, then it's, okay, you have the data, but you don't really make use of it. So I think if the front end gets developed like that, that would be possibly a bit nicer to use.
You know, this has been, this is an ongoing dispute. How to provide information to the patients. And whenever you start publishing some health data, then there is lots of discussion around ethics. And what physicians typically are afraid is that patients come to wrong conclusions. You're just reading this data here, and then they want to control it. So the physicians want to control the context where patient learns about the information. And that's why this public sector patient portal is a little bit lagging behind. There are the private apps that are designed for specific chronic conditions or specific patient groups. They are much more informative than this public one, because here it's very difficult to come to some kind of compromise that, okay, let's provide this trend line for these patients, and then agree that, okay, when you read this, what you do you just get depressed, or do you go to the doctor, or do you eat some crazy drugs, or what do you do? So physicians really want to control the context, how patient gets this information, and this is holding back actually just developing this on the public sector level, this kind of decision support services for the patient. Even for the doctors, the same. Like we have this problem, too much information. I'm coming to this later, but there is no really easy solution. How to aggregate the information for the decision making in this point, and it's especially difficult with the patients. So Estonian healthcare is generally, these are hospitals. So hospitals, we have like Tallinn is a capital, and Tartu is more like a southern Estonian capital. And here we have regional center, here we have regional health center. And then we have more of these county hospitals, like you have these Himax and general hospitals. And in Tallinn there are also a couple of city-managed central hospitals, general hospitals. And these areas are like these catchment areas, 30-minute travel, so you can see how small Estonia is actually from the territory perspective. So it's 300 kilometers here, and this is all you get. You start driving in the morning, and by the noon you are in Russia or in Latvia. Okay, and from the software perspective, these county hospitals mostly use the same hospital information system, but the big ones develop their own systems. And then there are some alternatives which are also used by this more bigger hospitals, which can allow this kind of internal support and negotiation power with companies. But mostly there are hospital systems, are like 4 softwares available on the market, let's say. And family health centers are also scattered all over the place. Of course, mostly in bigger centers and in some other towns. The policy is roughly like 1,000 to 2,000 patients in your list, and then they try to keep this availability of the GP service all over the country. But we have this problem that most of the GPs are already quite old and working as came back from the retirement to work, especially in some rural areas, and now the health board has really difficulties to get all these places supplied, like family health centers with professionals. And again, one of my colleagues is having a family practice on this island, Vormsi Island, and he goes there maybe once a week, and the rest is just providing tele health services, and there is a nurse on the island. And of course there are very little people during the winter, but in the summer there are more people. And also now already this town here, this is a town of maybe like 20,000 people, or maybe 10,000, I don't know exactly. But and they have difficulty to find new GP. The old GP just retired, and they don't find the new GP. And again, my colleagues just provided the same telemedicine service here now in this small town. So that this is the difficulty of getting all these GPs positions filled. And but the software from the EMR perspective, they like 85% they use the same software. There is a like GP. Sorry?
What's the number of GPs?
Number of GPs is, I think, some 800. You can basically calculate if you take 1.3 million and the size of the list is 1,500, and then it's roughly like what you need to cover the whole country.
Expert a lot of GPs.
What is the number of medical universities, medical schools?
Medical schools. We have one university in Tartu which trains doctors, and then have special schools also in Tallinn, which is Tallinn highest medical profession school or something, and also in Tartu. Yeah, two basically. Yeah, I think so. Yeah.
Basically one medical school and the others are probably specializing.
And the school question is something that brings us to the interoperability. So if you want to agree on the meaning of some term in healthcare, then all physicians roughly are coming from the same school, and they even remember the name of the professor who told about this term, so that they mostly agree on this. But if you have more schools or more backgrounds of physicians, then the terminology definition becomes also a little bit more difficult, because you don't have this basic same training behind these physicians. So 85% of software is roughly the same package, but then there are alternatives. GPs also use one smaller vendor software in some cases. Then they use this government-provided clinician portal in some cases, and then there are also like 4 different kinds of typically that they use. And if we look at the special service like dentists and labs and pharmacies and so on, then they have also alternatives. They have many software packages. So roughly the market is, it's very similar from the size perspective. Like here you have like some 20 softwares, which some here and there are used for certain special services or cases. And the history of development of this software, so also government sponsored developing this is hospital information system Ester, first version, second version, third version, and now I think majority of these county hospitals, they use this third version that was originally developed very similar, like maybe this Huawei case here. That there is something that you just use because you want to get insurance claims calculated, and you just start recording. And then another software was created. This is also used by a couple of hospitals, and then another software is also used by a couple of hospitals. And then the GP software also started 97, but then there are many third-party EMRs available also, which do similar things. But it all was mostly driven by this electronic insurance claim specification. This really drove the use of all this software, the local systems in hospitals and GPs and clinics. They started to use software because they wanted to get money as soon as possible. Okay, and then later just started to introduce the e-health exchange standards, what we are developing right now here. And then all these software systems had to be updated to support this exchange, and then the central systems, national EHR and PACS and the prescription system were created to facilitate the central management of the change. So you can see that there are local systems used by different specialities, different condition situations, and then there is a standardization line that you agree on certain digitalization way, how you manage define terms, how you define data, how you define events, and then then there are centralized services which manage this central data sets, medical registries, and today when we are working on this future thing, we are talking about this precision medicine or personalized medicine, and we have this. Genetics project now, the number is 200,000 donors, so like 1/5, close to 1/5 of the population is has donated samples for the genetic research, and we are working how to make use of this now. This is very expensive research. Government is putting lots of money there, but we have to bring the research back to this GP and hospital decision making, and this is what we are struggling. When we started with the national EHR development, EHEP development, we established a special agency. Not really agency, it's a foundation. It's independent, again, operates kind of like a company or no, foundation, okay? And this foundation was founded. We tried to gather as good as possible decision power of Estonian Healthcare into this management of this foundation. So of course, government was involved through the Ministry of Social Affairs. Then Society of Family Doctors was represented. Then the regional hospital, Tartu University Clinic, one central hospital from capital, Tallinn. Then Union of Estonian Medical Emergency also. Then North Regional Hospital, so big regional hospitals were in the board of this foundation, and also generally the Hospital Association also was represented. So if anything was wrong with the implementation or deployment of the digital services, then this Estonian eHealth Foundation board was really a good place to go and complain, because then the hospitals managers just were there, and then they had to say something about it. Why they don't send discharge letters, or why don't they implement this new coding, or why don't they cooperate? So it was very easy access to the majority of the decision makers in order to get these services really deployed. And then there was management board, like any organization has, and then the staff for operations, and the organization then provided services to the users. So the users, GPs, hospitals, some nursing care, patient portal, health authorities, they were kind of the users, but they are represented also as like owners of the same foundation. So that you can see that family doctors here and there, hospitals, many of them included. So this was the governance, how we decided to make this project coordinated. We took it away from the ministry. It was a separate foundation which just managed the project. And here are some historic numbers of funding of this organization. And basically, at the beginning, it was the base operational cost was funded by government budget through the ministry, and then all the major development projects were funded by some support money. Like here we have World Bank or Asian Development Bank and some other. In Europe we are using quite a lot of these structured funds of Europe for developing this kind of projects. And later we introduced this additional line of financing, and insurance added into the service fees a small amount of IT integration fee. Okay. So when a hospital or clinic applies to the insurance that please pay for these services, reimburse these services, then according to the contract with health insurance, you get this small amount of fee only when you are properly integrated with the national health information system. So that like you are eligible for this funding only if you cooperate. And okay, the numbers are always funny for our Western colleagues, because they are many orders of magnitude smaller than rich countries are used to see. And we started with empty system. We didn't do migration of old data. And this also resulted in this, that the interests towards the data in the system queries were like 0, 0, 0, 0. Then it started to grow when there was point to go and see if maybe the patient has already former records. And so now it just goes and exponentially, and we have not seen yet plateau that probably at some moment it should plateau, because GP or physician can't do more and more queries all the time. So there must be some place where it stops, but now it has been growing. Also probably because of new standards being implemented, new document types and new services in the central system. And this fluctuation often shows just a seasonal change in the disease, and so the summer vacation nobody gets sick and these kind of things. So the acceptance, we have like 100% of prescriptions are digital. So there is very small amount of papers which are just because of very unique, specific new services or something where there is no software or something. But basically, it's all digital because it's related to money. If you want to get reimbursed, then you have to process the prescription from the pharmacy as fast as possible, and the fastest way is digital. So it goes digital. Hospitals also behave nicely. They send their discharge letters. Outpatient care is more struggling with the coverage, so they don't send the data out all the time. They just have other priorities somehow. The same with some special care, like this dental care, for example, here. But already lots of dead people have also records, because time is going, and so that there are more patients than population.
Why is that more than the population?
Because people have died and new people have born, and so it grows, Okay, the governance landscape we already discussed. So this is just the textual information of the same image. So we have Minister of Social Affairs, who plays from the public sector side, Minister of Interior, Minister of Justice, Ministry of Economic Affairs and Communication, and then the healthcare providers, which is typically like private sector providers, and this is the landscape we have to make decisions. What kind of services are made available, how they are integrated, who is responsible, and so on. And the same image we already discussed. And if we look just at the services, like from the organization level go into the services, then we see the little bit different terms, but basically it reflects the same thing, that we have population registry, legal entities registry, address registry, X-road services registry, e-health related things, healthcare professionals, healthcare providers, health insurance, medicinal products, laboratory services, interoperability. And this interoperability registry is like what is the fire.mn, for example, page. So this is something like this.
Can we take a look at that registry?
Absolutely. We can spend days looking at it. Then we have so to say operational data systems, which actually exchange the health information, like really transactions so we have this National Electronic Health Record System, National Picture Archive, Prescription Center, and there is a special integration platform for lab ordering system, so where the labs send out the list of services, and then also the orders come through this system. This system also supports reports, but now reports are also copied here. So you can, so now we are kind of in the transformation in this regard. Healthcare management uses reimbursement claims system, statistics reporting system, and there is a special module attached to this EHR also, which generates some statistics out of the EHR. And then there are some research databases and open data available. So you can see healthcare statistics and research database, which is maintained by the this health development agency, or the institute of like the National Health Development Center. Okay, Genome Bank under the University of Tartu. And some statistical or diagnosed registries, but I have already discussed, and maybe it comes up later, that there is still a little disconnect from this operational data to these healthcare management or research data. And it improves. There are some statistics in here published based on the records here. The genome bank is when you donate blood to the genome bank, then you sign a consent that they can use your health records, and then they import also your health records. And then these registries only do some research activities comparing the operational data and their data, but actually they collect data separately, directly from the healthcare. They don't collect from the national platform.
It would make sense to just directly collect from the EHR.
Yes. And we can organize this landscape of services in many different ways. Here, it just shows that we have private level of local systems, and then we have common services from the government. We have services which kind of drive the e-health, where we record policies. We have healthcare interoperability standards and e-government interoperability standards. We have different registries, population and legal entities and digital certificates and services and healthcare ones. And then in the other end, we have something where we see how it works, how it actually worked out. So we try to drive it through setting some policies and registries, and then we measure how it works actually. Here we have like hospital management software systems where they see how hospital performs, and we have a healthcare reporting portal where the health board and ministries collect statistical evidence that how healthcare works. We have some statistics modules and insurance claims where we see how it actually turned out. And then we have research also, which kind of helps to provide evidence how healthcare works. And then we have this operational data where actually the healthcare is happening, the real service is happening. So here I just try to map out these different services, the different roles, how they are positioned in the whole landscape. And the HIEP or this national EHR is just here. Well, maybe the HIEP is not a good use of term here, because actually in the Mongolian case I think this some healthcare provider and service registry may be also part of HIEP, and maybe we consider PACS also part of HIEP, and maybe we consider lab orders and results also part of HIEP. So it depends how you define your terminology in this architecture landscape. But the also one important thing is that not everything is e-health. It's just general government provided services which are very important for running this healthcare system. Because if you are not in the population registry, then you are not patient. You can't be just registered patient because you don't have ID and the legal entities. If you're not hospital, then who are you? And this is just general government registries. Okay, this we saw already.